And so with that, I'm going to go forward and introduce our speakers for the day, and the topic being CBC Pathway Home. We have joint presentation that will be given by Danica Mills and Mark Graham. Danica Mills is the Executive Director of Coordinated Behavioral Care, Inc. and Coordinated Behavioral Care IPA in New York City, New York. Danica is a licensed clinical social worker and art therapist with leadership and clinical experience in hospitals, schools, shelters, and nonprofits who use collaborative care approaches that integrate health information technology solutions to drive improvement in health outcomes. She's the Executive Director of Coordinated Behavioral Care, Inc., a nonprofit that operates a health home serving over 25,000 New Yorkers, an OMH-funded care transitions program, and a health coaching program. She is also the Executive Director of the Coordinated Behavioral Care Independent Practice Association. Before CBC, she directed a New York State chronic illness demonstration product that piloted care coordination for Medicaid recipients with complex disorders, led a SAMHSA project in 2 shelters that successfully engaged chronically homeless women and men in services using evidence-based practices, publishing work using critical time intervention and seeking safety, and winning a SAMHSA Science to Service Award. And most importantly, she is also a mom of 3. Mark Graham, who will be her co-presenter, is the Associate Executive Director, Operations Coordinated Behavioral Care, Inc., and Coordinated Behavioral Care IPA. Mark Graham is a licensed clinical social worker who throughout his career has worked in the nonprofit sector to improve the quality of care and outcomes for individuals experiencing social, economic, and health-related crises. His work has involved the development and management of programs serving the homeless, people with serious mental illness, and those with chronic health conditions. After years of providing and managing direct care programs, both in New York City and Dublin, Ireland, Mark joined Coordinated Behavioral Care, where he designed, implemented, and managed Pathway Home, a critical time intervention program that has achieved great success and continues to grow with the support of the State Office of Mental Health. In his current role as the Associate Executive Director of Operations at CBC, Mark has responsibility for the development of new and innovative programs that use evidence-based practice to provide comprehensive, results-driven care services across New York City. So Danica and Mark, I really thank you for giving your time to us and your knowledge, and I will turn over control to you now.
Thank you, Lee. Thank you so much for the introductions, and thanks to both you and our partners at GSI for having us today. What you'll see on the slide is an overview of how we hope the presentation will go and what areas we'll touch upon. And I'm most importantly hopeful that by the end of this presentation, you'll have more of an understanding of how CBC and Pathway Home, the architecture of the organization, allows for creative solutioning. Also, I hope that our participants can walk away with a deeper understanding of 3 things: how social determinants impact care, how engaging people at an acute time of need by offering them both value and care that's meaningful will have the greatest effect, and finally, that the underlying focus of the triple aim for better outcomes, better care, and lower cost is politically agnostic. In this time of uncertainty, those goals will not go away. So Lee, we're having a hard time advancing to the next slide. There you go. We have control. We'll go on to the next slide to talk about CBC. Coordinated Behavioral Care operates 2 related service entities that help New Yorkers access quality care coordination, treatment, housing, employment, and other needed services. Collectively, we're a results-driven healthcare organization dedicated to realizing the opportunities under Medicaid redesign to improve the quality of care for folks with Medicaid who have serious mental illness, chronic health conditions, or substance use disorders. We are quite new. We were launched in 2011 by innovative New York City behavioral health agencies, and we've pulled together their expertise in the community to deliver these integrated services. both medical and behavioral health care, to help achieve the triple aim. Our vision is to create an environment where New Yorkers, especially those most impacted by social determinants of health, received coordinated, individualized, and culturally competent care that's effective in preventing and managing chronic and physical and behavioral health conditions. Our aim is to help many, many more people in our city live long, healthy, and fulfilling lives. What you'll see on the slide is the two related service entities, our largest being the Health Home that operates Pathway Home, and you'll learn more about today. So on the next slide, you'll see information specific to New York City and New York State with respect to the avoidable readmissions within 30 days of a discharge from an inpatient facility. This is why we do it. How most importantly is that the number of past hospitalizations that a person have puts them at greater risk for admissions within 30 days. The cycle illustrates all of the places that an individual can end up, particularly those with serious mental illness, that can be a transition from an inpatient unit, from a shelter, from a longer-term stay, such as a state facility, and in the community. So at every place along the way, there are opportunities for crisis, big or small. And so for an individual with serious mental illness, even a small crisis can affect and impact the cycle. To mitigate this, we have specific values that distinguish our services in that they are individualized. We believe that healthcare is person-centered and respectful of every individual's cultural background and individual values. We're outcomes-oriented. We want to continue to learn from best practices in the field, and by also taking risks, knowing what we know, pioneering new and innovative approaches. We want to continue to thread together that individuals receive customized treatment that is designed so that they can yield the most optimal health outcomes. And lastly, that care is timely. If we provide the right treatment at the right time, it yields better long-term outcomes. By identifying issues early, individuals can avoid potentially more pervasive health conditions. You'll see these themes throughout our presentation. On the next slide, our experience is that when this particular revolving door of the hospital cycle becomes part of somebody's life, it lowers their individual expectations for success in the community. So our goal isn't just to allow people the opportunity to function, and here's where I'm going to use air quotes to talk about the function as best as possible, which has a negative connotation. We want to create the future of their care with no limits. Imagine you have a cycle where you're just expecting the next hospitalization because nothing has shifted or changed when you went into the hospital. Now you're expected to find transportation home. You may not even have sheets on your bed. And to make those transitions, having just recovered from either a medical or behavioral health emergency. In New York, and from a national perspective, this is important. When community services like health, housing, and vocational services communicate well with natural supports, it ends up coming together in an intervention like Pathway Home. In New York, where there's a right to housing, we have examples of when a shelter provider is pressured to act quickly and move people within the shelter system without discussion amongst their providers. So imagine that impacting not only the cycle is a transfer of care. So with every transfer from one type of service to the next, there's an opportunity for crisis, an opportunity for information breakdown. We'll talk today about how these systems can work together in daily practice. So on the next slide, we'll look at the factors predicting readmission and the importance of the social determinants of care. This will be a term you'll hear a lot from us as the research is catching up with what we see impacting our members' lives. Since 2014, we've launched effective gap-filling services for low-income New Yorkers that build on the expertise of the community-based services, and that we knit together affiliated programs to address treatment and recovery needs, acknowledging that the impacts of social determinants of health have such a great effect on individuals and families. For example, housing insecurity creates a justifiable anxiety that can exacerbate somebody's underlying conditions. Our goal is to gain a unique understanding of each person's critical needs that they have to address for their health. On the next slide, I'm going to transition now to Mark Graham, who will talk in greater detail about Pathway Home and how we impact and enhance the system of care for folks with serious mental illness as they transition from the hospital back to their community.
Good afternoon, all. It's a pleasure to be with you this afternoon and to have an opportunity to talk about Pathway Home and the work that we are doing here in New York City. As Danica mentioned through her slides, New York State has an incredibly high readmission rate, and I believe nationally it is very similar in the number of individuals who return from hospital but are readmitted within a 30-day period. It's something that was and continues to be a stat, despite the fact that in New York State there are a number of care management programs in place, and programs that we are fortunate are well funded. But what we continued to see was this reoccurrence of people returning to the hospital within 30 days of discharge. As Danica mentioned, that CBC is a membership organization, and we are made up of 50+ nonprofits across the city, have a lot of expertise in providing care to those individuals when they return to the community, and really came together to look at what we could be doing to provide a more intensive care to those individuals through that period of transition. We formed, an approach and were awarded a 1-year grant, which is where Pathway Home was born. And I will move forward to the next slide to give you a sense of the population that we are working with through this program. Pathway Home was designed to work with Medicaid recipients. We've been fortunate since then to be able to expand that to work with individuals who are on other insurance, but also to work with undocumented individuals. We really wanted to look at individuals in the hospital system who had been there 15 days or more. And our reasoning behind that was that in New York, the average length of stay for someone in a psych admission is 7 to 10 days. And by working with individuals who were there for a longer period, we realized we'd be able to target those individuals who needed more time to stabilize in the hospital, and who are likely have more difficulty in their return back into the community. It also gave us an opportunity to work with state psychiatric patients. These are individuals who have perhaps been in the hospital for over a year, who face a real crisis sometimes as they transition back to the community from their stay in a state facility, and often lack the skills needed to make that to adapt back into community living. By also focusing on this group of 15 days plus, it meant that we could work with a smaller pool of individuals, so that when we were testing out this pilot project, we could look at a pool of individuals who had more chronic needs, who had a higher risk of readmission rates when they returned to the community, and whose needs were not being satisfactorily met in the community. One of our targets and what we really wanted to work with were those individuals who had difficulty obtaining or maintaining housing in the community. Danica talked about risk factors for individuals and social determinants that can impact someone's ability to maintain their health in the community, and housing obviously is a huge part of that. And so we really wanted to look at people who the hospitals were having difficulty placing back in the community in appropriate housing, so that we could be an additional support to ensure that they were being placed in appropriate placements. And finally, one of our targets or eligibility was that we wanted the individual to be open to receiving services. This is a voluntary program that we set up, and the importance behind that voluntary component is the buy-in from the individual. We found at times not all individuals, when the social workers at the hospital offered the services, were accepting, but that provided us with an opportunity to provide education. And what we discovered, and perhaps is similar with the populations that you serve, is that there was a little care fatigue with some of the patients who had been through the system previously before. And so being able to engage with them at the hospital, and I will speak more to that, allowed us to really explain the program, and to, particularly because it's a time-limited program, to get their buy-in to be able to provide the care for them when they return to the community. Next slide. In our Pathway Home program, as I mentioned, New York City had care management programs for mental health in the past and continues to do so, but we wanted to adapt the program that we were offering so that it was more evidence-based. So we could look at a model of care to provide more intensive care for individuals while they were on the program. And we worked to adopt the critical time intervention model of care. Some of you may be familiar with CTI as it's more commonly known, but I think it's important here to give you a brief overview so you get a sense of the intervention that our Pathway Home program offers. As I said, first and foremost, CTI is a time-limited model of care. It works for individuals for a maximum of 9 months, and it works with them critically at a time of transition. Transition, in our case, refers to individuals returning from a hospital setting back into the community, but can often refer to other transitions where there's a potential for crisis, such as individuals leaving the homeless system to move into an apartment, or people returning from the prison system. But our focus was working with those individuals as they transitioned from hospital. CTI is one of its main focuses is stages. It works in 3 phases. And in those phases, the workers on the team provide different levels of intervention. And in the first 3 months, that level of intervention is much more intensive. That you work with the individual and can see them several times to provide appropriate clinical-led interventions, and work with them in identifying their network of community supports. And it's beyond recognizing their network, but also ensuring that they are linked with that network. As we go through the presentation, I'll talk more specifically about the services that are tied to each stage, but the first 3 months are what is considered the most intensive stage and focuses solely around their transfer back into the community. The second phase is what they call the tryout period. It's a time when the worker works with the individual to see how they are, and shadows them in the community to see how they are managing their own healthcare needs and their community needs. It's a time when individuals, the workers move from a stage of advocating for the individual to empowering that individual to take control over the decisions they need to make around their social needs and also their healthcare needs. And then finally, the client moves through to phase 3, which is the transfer of care. It's an opportunity for the individual to step down from the care that we would be providing to them, to finalize and ensure that they have the appropriate supports in place, and to make adjustments if there's a need so that they can get additional care supports they might need to manage in their community. The 3 stages gives the individual, and it's something that I would sort of echo again when we've worked with engaging individuals. Individuals that we've found are very happy to work over a 9-month period. They see an end in sight when they come into the program to start with. Often we find towards the end of the program they would like to stay on longer. But what we have found, it really encourages buy-in when our clients know that this is a very focused intervention, and that it's explained to them that at different stages there will be a different level of intervention by our clinicians. Moving to the next slide. To give you a little bit more of a general overview of how the CTI program works, and in particular how our Pathway Home program works. We are made up, it's our Pathway Home program, each team is multidisciplinary in nature. We have a team made up of peers, nurses, social workers, and case managers. In a CTI model and our Pathway Home model, they hold small caseloads. So we have an opportunity where they work with 1 to 15 cases. The rationale behind that is around the intensity of the level of care that we are able to provide. With a small caseload like that, the individual is able to really actively engage with the client and provide the sort of intensive support that they need, particularly through the period of transition. Each client is assigned to a CTI worker, so they have an identified worker on the team. But something that's important in the model is that they also have the support of the whole team. And so the person may be assigned to work predominantly with the social worker, but our peers are there to help provide life support skills. Our nurses are there to work with them on medication management. And so it becomes a real team effort, even though the client that we work with has an identified worker on the team that they have a connection with and can be a contact point for them at any time through crisis. As the slide shows, our care covers a lot of different areas. And we'll go through sort of the individualized services. But for the purpose of your understanding, individuals can be touched at different stages. So if someone may need medication management at a particular point, it may not be at the same point as someone else. So the services and the interventions that we offer are really tailored uniquely to the individual that we serve. Also, there can be a reoccurrence. So someone may return back into the hospital and it does not consider a step back because this is a sort of all-embracing intervention. So we follow people through all the different stages of their transition over the course of the 9 months. Next slide. Here we have a list of the services provided. So to give you an overview, and this hopefully will help explain in more detail the work that we are doing and perhaps why we're seeing some of the positive outcomes that we are having. Our services begin at the hospital. And this is something that is very important for understanding the Pathway Home model, and particularly in our sense, the outcomes that we have had. We encourage the hospital system to make referrals as early as possible. Our reasoning behind that is that we want to start our engagement at the hospital. Traditionally in New York City, with mental health programs, a referral would be made and the community-based team would be lucky to see the person on day of discharge, but more often would be actually trying to engage them once they had been discharged from the hospital. Our early intervention allows us to meet with the person at the hospital, to use that time to identify any immediate needs that they have, however basic it may appear, and addressing those immediate needs can help with the buy-in to the program. So for example, we had one patient who had been in the hospital for 18 months, and talking to her, she talked about her boredom, in particular the fact that she was an avid reader and had read everything in the library twice. It was an easy solution for us to find out the types of novels she wanted and to be able to return the next day with books for her to read. That small little effort paid dividends when she was discharged from the hospital because she felt listened to. Furthermore, that early engagement allows us to work with the hospital discharge planners. Our expertise as an agency is our knowledge of community-based services and the needs that individuals can have in the community. Our hospitals are great partners, but often due to pressures upon them and perhaps lack of knowledge of the services in a patient's particular neighborhood, they're unfamiliar with what's appropriate or what's a good service to refer someone to, and often will just refer to where there's a vacancy. So being able to work with the person initially at the hospital and the discharge planner allows us to really tailor a discharge plan to what the needs are of the individual. And we're building up relationships with the hospitals allows us also to delay a discharge by a day or two if it means that a vacancy would be available for a person in a more appropriate program. To facilitate our early engagement with the hospital, we do a rapid response to any referral that is made to us. We use an EFAC system, and we respond to a referral with an acknowledgement within the same business day, and usually a visit to the hospital for intake within 24, max 48 hours. On discharge from the hospital, something else that has proven very successful, and again, something that would be considered a small measure, is being there to accompany an individual home. I will talk a little bit more about some of our support dollars that we have, but being able to be there and to meet a person's immediate needs on the day of discharge, again, is very beneficial at getting their buy-in at a later date. By taking a person home, you can assess immediately what their condition of their apartment is, what the condition of their housing and their neighborhood is, and any obstacle that could be identified, perhaps for a person getting their medication or attending to future appointments, can be noted, and a plan can be put in place to address those. We also use our peers and our case managers to accompany people to initial appointments. One of our goals is to ensure that people make their initial outpatient appointment. In New York, that is often scheduled for within 7 days of discharge, with behavioral health, with a physical health appointment within 30 calendar days. And so we, on day of discharge, find out where those appointments are, where those clinics are, and ensure that we can be there to accompany a person to those appointments. We work with individuals around medication management. What we have found, and I'm sure is similar to individuals that you serve, is when we return to their apartment, we find a lot of different medications for the same condition prescribed by different doctors. And we've been able to work with local pharmacies who will take all the medication that we've identified at an apartment with the patient's consent and contact each doctor to determine whether it is a valid prescription and a current prescription. We're able to work and build our links with community providers. It's a key part of the transition work that we do, ensuring that the individual is getting services at an agency and a community provider that meets their needs and is one of their choice. Often people are discharged or seen at clinics where they don't maybe perhaps like the therapist, and so by working with them to get reassigned to a new clinic increases their likelihood of attending future appointments. We work to expedite housing placements within our network. Housing is a huge challenge in New York as it is elsewhere, but we work to sort of identify what the particular needs of that person are, if they're mobility issues, if they're originally from Brooklyn and want to return to live in Brooklyn, finding housing in a place where they choose to live. Other work that we do in our initial 3 months of engagement in the community is skill building. Part of that involves in New York City travel. We have a great public transport system but can be hard to navigate. And also we have to look at the experiences of our clients. We had one woman who returned from a state hospital after 12 years, very enthusiastic and keen to be back in the community, but missed her initial psych appointment. And when asked why, she explained that when she got to the subway station, they no longer use tokens. And she wasn't aware, she'd never seen the swipe card that are currently being used and didn't know how to use it and was too embarrassed to ask. So working and helping someone train them through the transport system, again, can increase adherence to community services and community appointments. We work with people on substance abuse, looking for triggers through that. We work on wellness, self-management, using our social workers to do therapy with the individuals, and also ensuring link with medical care. And I would just emphasize, as we finish this slide, is that the initial 3 months, as I said, when we talked through the stages of CTI, our teams can see someone up to 4 or 5 times a week. They could see someone 7 days a week. It's very much based on the needs of the individual. If an individual needs phone calls as support, we would go with the phone call option. But in-person meetings would be determined, and we would be there to see a person. Plus, our visits with an individual can be for several hours, so they're not short-term interventions, and again, hence the small caseloads that we have for our teams. Talk just a little bit more about, I touched on the medical. Something that we've seen here in New York, and I'm sure is also nationwide, is the connection between the physical and behavioral health conditions of our client group. For too long, things here in New York have been siloed, with the behavioral health working almost separately from the physical health, and there has been a move for more integration. And it's something that we have included in our team. By having the nurse there, we can really work with the individual on any identified physical health problems, ensure that when they go to their PCP, their primary care doctor, that they are getting an understanding of their physical health conditions as well as the behavioral health conditions that they have. What we found and where we've had success here is that previously a lot of people would be readmitted to hospital for physical health grounds, and because of behavioral health issues would get transferred to the psych ward. So as we work to reduce hospitalizations, we see that there's a huge importance on working and helping individuals around their physical health needs as well. Next slide. So to talk briefly a little bit just about the crisis management component of our work. Our CTI teams have a rapid response approach. They technically work Monday to Friday from 8 to 6 or 8 to 7, but we have constantly got someone on call. There is a willingness by staff to also work on weekends, particularly if an individual is discharged on a Thursday or Friday, which happens a little all too frequently, that we can be there to see a person over that first weekend once they've returned to the community. Our teams are mobile, so they spend 95% of their time in the community engaging with clients, but allows them to use technology. So our clients, as they come out, are often provided with phones so that we can text message, but that can go beyond that. Our teams can be reached whilst in the field and respond immediately to a crisis that might be arising. And being a team working together, if an individual is in the Bronx having a crisis and their main CTI worker is based in Brooklyn, they can reach out to their team for whoever is nearby to be able to go out and meet with that person and their caregivers or care network to work through any sort of identified crisis that is developing. Next slide. And I wanted to leave a few minutes just to talk about our enhancement funds. Something that came from our Pathway Home grant and something that we had asked for was for money to be set aside that we could use to provide additional support services that may not be automatically available through Medicaid or needed immediately through an immediate needs assessment. And those things range from very simple stuff, such as food. Often we would return home to find a person's fridge was empty and it's a Friday afternoon and their food stamps have been switched off. Being able to provide food for a person to carry them through the weekend. I mentioned about accompanying people home from hospital. Often these people, as I say, have been at least 3 weeks in the hospital. So we would use Uber car services, or a taxi service, which would allow the person to be able to be transported home so they wouldn't have to navigate public transportation in order to get back home. We would be able to provide simple things like Metro cards to get people to and from their appointments. But beyond those sort of more basic needs that would be identified, we were able to help in other areas. We were able to provide people with gym memberships. And this is not something that we as a program would sign a person up for. It was when we were asked. So a lot of our clients would talk about boredom. that they were sitting at home and they had nothing to do. They're perhaps poor exercise, they had diabetes or other health conditions that would benefit from more regular exercise. And connecting them with a local gym. In some cases, we paid for private training sessions so that the person could learn to use the equipment. If you're anything like me, it can be a hard thing to sometimes navigate a gym. So being able to pay for that helped someone not just join a gym, but actually feel comfortable using it. We were also able to pay for college courses for people so that they could get back into the workforce, whether it was cooking classes at a culinary school here in the city, to English as a second language classes. But beyond that, we use technology as well. And one example that I would just like to highlight is around medication. You see up there in the upper left-hand corner is what is a medication dispensing device. We had a client that came to us who had had 2 hospital admissions in the last 6 months with very serious suicide attempts. She was a woman in her 50s who suffered from very severe depression when she was not medicated. When she was referred to us, the hospital said that she was just non-compliant with medication, that she had no interest in taking her meds and did not want to manage her illness in that way. She lived in a supportive housing program who considered her too high risk for her to be able to return to live at that program. And so we arranged, when we met with her, she said that she did want to be on her meds, that she just forgot to take them and that she was forgetful. So our nurse was able to source this machine that allowed for him to put in her medication. If she missed a dose of that medication, would receive a text message. He would receive a text message, and also her niece, so they could make a reminder phone call to her. And as a result, she remained compliant with her meds in the community and was not readmitted to the hospital. Okay. And so to give you a little bit of sense of the outcomes that we had on the next slide, it looks like, just to note that what we're showing there is the percentage of people who are not readmitted to hospital. So as Danica had mentioned at the beginning, the readmission rate in New York State hovers around 21% within 30 days of discharge. On a Pathway Home program, we were seeing a rate of 2% as our average across the year. And next slide will just to highlight a little bit. It's something, again, I'm sure is across the nation. And the majority, even of our 2%, were within the first 30 days. And you can see through the slide there that there is a steady decline. So the longer someone remains out of the hospital, the less likely they are to be readmitted. And then my last slide, oh, sorry, 2 more, was just to give you a little bit of a sense of our intervention. As I said, it is really community-based. We do attempt to provide our services in person, but in order to be able to work as intensely with some people who are in the early stages of transition, a lot of our later work is done by phone calls. Certainly in the last 3 months, actually more of the work is done by contacting collaterals and other care providers to ensure that the person continues to be engaged in care. And so basically, one way of putting it is that over the course for 9 months, we wean the person off the more intensive care so they don't become dependent on our program, so that at the end of the 9 months, it is easier to hand over their care to their other providers in the community. And if at the end of those 9 months the person is identified as needing a higher level of care, we can use our ability to ensure that they get linked and connected with more appropriate, more intensive care. And finally, for my slides, is graduation rate. So of those who came onto the program, we have 68% who at the end of the 9 months positively graduate. And that 68% are individuals who at the end of our time working with them are connected with other community support services, are living independently in the community or in a supportive housing residence, and are not risk of hospital readmission. Of those 68%, 83% live by themselves and independently access supports in the community, while 17% were connected with a higher level of care, something like assertive community treatment, also known as ACT, which is, again, is a national model, but provides more intensive care here in New York City. And with that, I'll hand you back over to Danica.
Thanks, Mark. So on the next slide, we want to transition the discussion a little bit. Now that we've heard about the intervention, we want to touch upon how health information technologies facilitate the outcomes. If the goal is improving outcomes, one of the tools to do so is through a care management platform like GSI Health, a connection to a health information exchange or regional health information organization to get data in the hands of the people that can affect positive change. For example, we work with a care planning process that changes with every single hospital admission or touch or change in diagnosis or crisis, and so it's constantly adapted. We've abandoned the idea that a care plan is this static document that doesn't change. A care plan should adapt and change with the needs of the person. Health information technologies should be able to accurately record every single interaction that the individual has with their care network. And through the HIE, give that information back to the care team to also empower the individual to adhere to their care plan and give them the tools to do so. Appointment data and program management are also important tools and to help folks manage care. The important thing here is that we're not just focusing on health outcomes to drive better care, but also process metrics. We want to make sure that the teams that we work with adhere to documentation standards. They adhere to assessments, the training to keep a certain fidelity to the to the CTI model of care. And so on the next slide, you'll see an example of a report we can pull that helps our supervisors manage their teams. And so you'll see here an example of the information that we capture around a new referral, how many individuals that a person is serving at the moment. You'll notice, as Mark mentioned, the caseloads are very, very low because the intensity for this intervention is very high. How many notes that were written. And so those of you who are doing either care management or even clinic services, you'll see a huge amount of notes based on their caseload size. The other thing we like to keep in mind is that we give our staff the tools to be able to do their work in the community. We don't want to have travel impact their ability to do so. We don't want connectivity to impact it. So we pay attention and want that information into the system within a very short time period because it's accessible for the care team. So if you'll see the staff listed, many of those folks combine and have a particular care team. They need to know the particular events and appointments and interactions that have been occurring with a particular client. So on the next slide, you'll see some outcomes. We are happy to report that we have preliminary outcomes for this particular intervention, as Mark mentioned, and adherence to important quality metrics that you see here. An important note here that it's a highlight for New York State is the connection to a longer-term care management intervention called a health home, which is not a place but a network of services. Many states have taken on their iteration of health home, and our goal is to put this time-limited intervention in place and connect those who need it with a longer-term care. We do have a pretty intense length of stay. Our average is around 184 days. And at any time, should issues come up or crises, we have the program accessible to be reactivated. So on the next and last slide, we want to acknowledge that the future for care transitions like Pathway Home to support transitions of care that are timely, meaningful, and valuable, it's important that these three things happen so that it is important for the person being served, that they have an investment in their own future, because none of this work we talked about today would be successful without the belief of the person served that they can do it. And so through that relationship, they're empowered to attend appointments. They're empowered to get healthy. So this isn't something that we do for people. It is something that we do with people. We're finding here at CBC that care transitions can positively affect so many different populations. And what you see listed here on this slide are either programs that we are developing or programs that we're putting into place right now. We're finding, and we hope that you can take information from this presentation and adapt it both to urban and rural areas, but we know that different challenges are with both. Finally, we're fortunate to have the opportunity, prior to significant and far-reaching changes in how our healthcare is delivered and paid for, to have had such a positive impact on some of the most vulnerable New Yorkers, to allow them to live more stably in their community. We need to pay homage to them as well. So the ideologies of the Triple Aim need pathways, and this is one of them. Thank you again, Lee and GSI. We have listed our contact information. Mark and I are happy to answer questions you might have, and we are also accessible after this broadcast at the email listed here.
Thank you very much, Danica and Mark. I really appreciate your being forthcoming with your program's details, as well as the successes that you've had. So we want to transition into a small post-discussion, and then we'll have a Q&A period. But prior to moving into the next discussion, I want to just poll the audience. So if you're able to look at your screen for a moment, I want to just get a sense from the audience about a couple of things regarding the presentation. The first poll that I'm going to ask is, are you involved in a program similar to Pathway Home? And so you should be able to see that question, and then there is an opportunity for you to check as many answers as apply. So if you'll take a moment to just respond to that poll, I'd appreciate that. People are still responding, so we'll give it a little bit more time. Once again, you can check all that apply. Looks like the responses are slowing down, so I'll close the poll in 5, 4, 3, 2, 1. And so I'm now sharing the results of the poll. So looks like a number of you are, in fact, trying to address a similar target population as the Pathway Home program is, but there is also a reasonable amount of you who are not involved in a similar program, and very few of you who have the same kinds of providers and community that were discussed here. So this is good to give us a sense of who we're talking to, and certainly hopefully gives you a perspective on who you're on with. So I want to just have one more poll, and I'll do it now. And the question will be, what are or would be the more significant barriers to implementing a program like this? And once again, it is a multiple selection, so you can check as many things as apply. So if you'll just take another moment to respond to this question, and then we'll move forward in the concluding part of the presentation. Looks like people are still responding. Now the answers are starting to slow down. And so I'll close the poll in 5, 4, 3, 2, 1. So again, I'm sharing the results of the poll with you. It looks as though the majority of the group of the options that were listed here, obviously there may be other reasons, thought that financing a program like this would be one of the more significant barriers, and then followed by building the community network. And so I think that those kinds of considerations are certainly significant, and it makes it all the more impressive that CBC has been able to achieve what they have. So before I move on, I don't know, Danica and Mark, if there were any commentary you wanted to make regarding the answers to the polls.
Other than our observation is that we were surprised that no one thought that technology would be there, and our thought would be a little bit higher.
Well, technology is solved now, I guess.
Right.
Exactly. All right, so thank you very much for participating in those polls, and I want to just spend a few minutes talking about the principles that were espoused in the Pathway Home program and map them onto a model of population health management. And so as I started to say at the top of the call, we are a population health management solutions company, and we have a product called GSI Health Coordinator, and we're proud to say that CBC is a customer of ours. And our platform really has two major components. One is a set of tools around care coordination, and another is a set of tools around analytics. And we believe that those two kinds of activities should be tightly coupled, so that any insights that one gains from analytics can reinforce the care coordination and care management activities, and reciprocally, those things that are done in care management can directly feed into the analytics and be close to the point of the care delivery of the care team. And so that's in essence what we provide. But what I want to talk about is really about what our customers are doing or trying to do. And so we heard in the presentation from Danica and Mark that there's a need for change, and that there are a number of different factors that are involved, particularly as one tries to pursue the triple aim. I think that all of those things are certainly what we see across a number of different kinds of programs. But what we're also seeing is that a number of our customers deal with at-risk populations, and the ability to deliver care to those at-risk populations is fairly vulnerable. And so I'm just showing a headline from the Philadelphia area that came out recently this month, that North Philadelphia Health System files for bankruptcy. And among a number of other things that were going on, there was a noting that there was a decision by the state to reduce financial support in treating high percentage of poor and uninsured residents, and that forced them to close down one of their hospitals. And this idea of the ability to treat a population that has high costs, but doing it on a shoestring budget, is something that really puts this scenario of the care providers who are able and willing and located to deliver that care being at risk. This brings that issue front and center. And so the idea of value-based care, in part, is to allow the providers to take control of their own destiny, to assume more risk for their population so that they can take a bigger slice of the pie through their own efficiency gains. And so in addition to the quality outcomes and the way that it's important to make sure that each patient gets exactly what they need to become well and remain well, there's this underlying question of how is it that we keep the providers in those communities healthy themselves in terms of financially solvent in order to deliver the care in the first place. And many payers realize that this shift to value-based care is certainly a good idea in terms of having providers being partners with them in trying to ensure the populations are treated well. And it really requires an additional commitment on behalf of the providers to do these more intensive, when required, population health management programs, like we saw with Pathway Home. And so I want to just propose or lay out a model for population health management, and then I want to try to relate some of the principles that were talked about with Pathway Home to that model to show that population health management is achievable, and it matters how we think about it and approach it. So first I'll just look at the different levels of care management that typically go into caring for populations. One that's probably ubiquitous in all of your organizations is this idea of case management. So if you have a hospital, there may be case managers who are assigned particular patients, and that they manage their interactions and flow within the hospital and help to plan what happens outside the hospital. They make sure that all the things that are related to the payers are taken care of, et cetera, a number of different things that go on. But the scope or span of control or responsibility typically centers around the care delivery facility itself in the acute care setting. That's to be contrasted with what I'll call care management, where there's a broader network, maybe a hospital system with employed physicians under the same roof, or maybe some set of specific partners are also brought into the development of care. And there are a number of different kinds of programs that try to assemble these federations of organizations. And I think the first level of that is, who is it that still is under the same umbrella by and large as the convening organization? But then when we start talking about population health management, we start to involve this broader community and non-traditional participants in the delivery of care who are able to impact the health of those patients, whether it's delivery of certain social services or human services, or if there are organizations that facilitate patient outreach and having a relationship with the population members. All of those different kinds of things are now sort of brought into focus and incorporated when we start talking about population health management. And so we tend to see this evolution toward population health management that kind of moves through these stages and really depends upon a number of different factors in terms of where people start out. When we talk about trying to say what needs to happen in a population health management program, there are a number of different things that can be brought up. Some of them are listed here. We understand that patients in the current system aren't always presenting or complying with the things that they should do when they're away from the care setting. Or when they do present, they're sicker than they should be because there are things that have not happened in their care, or there's presentation in inappropriate settings, like overutilization of the emergency department in a hospital, for example. Providers are sometimes not informed of what other providers are doing and may do wasteful or redundant or inefficient care steps that that may contribute to the escalating costs around care. There's often not a propagation of best practices across the network of providers who are involved, and may not have some uniform system of the measurement of efficacy. So it's sort of a tall order to say what population health management can do. And so I want to look at the evolution that we see in organizations as they start down this journey, sort of starting with what are we talking about when we say population and population health management. Well, the obvious part of the population are patients who are coming across the threshold, patients who are presenting they are high utilized or have some criteria, but they're the patients that we're seeing now, trying to curb the thing that is most urgent and top of mind. Then there's the patients that we may not be seeing right now, but we've seen them before. We have a history of what they've done, and therefore we can do a little bit of analysis to anticipate whether or not we will see them again, and if so, in what capacity and what risks they have for re-engaging with the healthcare system. And then in some programs, there are patients that we haven't seen. That may be an attribution of patients that an organization or a network of providers are responsible for. They may just be the patients who live within a particular geography. However, those patients are defined, they may or may not have had a recent or ever had an interaction with the healthcare network that's being assigned to being assembled to deliver care to them. And so the trick on these population health management implementations often is, how is it that I can capture and account for in a deliberate way the biggest portion of this pie, so that all of the patients that I may be responsible for are at least considered by me, and I can plan my activities appropriately. So I want to now just talk a little bit about the continuum and the perspective that we might take when we think about population health management. So there's a continuum of being well to being ill, wellness to illness on the bottom of the slide. And what happens today is sort of a reaction to patients coming across the threshold and presenting themselves for care. And so patient presenting either in any particular care setting often is the first step in delivering care to someone. And this presentation typically is thought of as an encounter, and there's some treatment that's associated with the encounter for whatever the patient is saying is wrong or is discovered is wrong. There may be some case management to try to understand some extended needs that the patient may have, or to navigate particular aspects of the delivery of their care. It may result in some instructions for the patient to take care of, and maybe other things like referrals and the like. But then often the patient sort of exits active care management, meaning the professionals who have been assigned, maybe it's a case manager or others, to sort of help them through that portion of their care ends, and then the patient is meant to traverse the rest of their wellness on their own. And so the patient needs to be compliant with their instructions and do the things that are asked of them. This is really how a lot of care is delivered. It's the patients that we see now dealing with their immediate concerns, and then moving on and allowing the patients to be their own care team beyond the four walls. Unfortunately, because there's no proactive measures to actually address the patient before they present with a problem, this is where I'll say we see the maximum severity and utilization, meaning there's nothing that was done to try to reduce utilization or reduce severity. We're just reacting to patients showing up. So if we contrast that patient health response and try to apply the idea of population health to this kind of reactive system, then we may do some sort of characterization of a population of interest. It still may be based on patients who are sick or I've seen before, so it's still toward this illness side of the spectrum. But when a patient presents, I may have some initial interventions that I try to enact, such as the diversion of the patient to the appropriate level of care. Rather than having patients come to the emergency care, I may have them go to urgent care or other things like that. But then we also start to think about, in this population health mindset, the idea of the episodes that may transcend across care settings. And so when there's what I'm calling an episode encounter, all the things that happen in a treatment encounter and case management, et cetera, are a part of that, but it doesn't stop with the care setting that the patient has showed up at. Then there's a reconciliation of the patient with a particular population that is going to have to define the protocols that will apply to the patient, and we can plan what the care should be for the entire episode. And so this idea of planning the episode takes into account the things that we would normally do with case management and giving patients instructions, but also takes into account any particular protocols that we've pre-thought and predetermined would be applicable to this kind of population, so that there can be an establishment of a repeatable process with dealing with those patients. With that episode planning, there's obviously then engagement of both the patients and the care team members across the continuum to facilitate that episode, and then the interventions that are associated with that episode can be carried out. These obviously are a result of the planning and involve the patient, and they still have to be compliant. But the thing that often is added in that's a game changer is the addition of paid professionals, i.e. a care manager or community workers who are part of the care team, who are there to help the patient continue to move beyond the encounter and through the episode toward wellness. So the patients aren't trying to do it alone. And through this care team, the population health management is accomplished, and then ultimately the patient exits the active care management and hopefully has achieved a level of wellness that they may not have achieved otherwise. But this is still reactive and looking at the patients that we see now. So if we want to go further down this idea of population health, then we can start to look at how do we have what I'll call population health follow-through. So it begins with the same set of steps that I just talked about, with the characterization of population, the patient presenting, and then going through all of those steps around the episode. But then, rather than exiting active care management, the patient moves into proactive management. And what I mean by that is now there's consideration for what happens to the patient beyond the episode that's concluding, and how is it that we prevent a similar episode or other anticipated episodes from happening. And so that may mean a reassessment of the patient in terms of what populations they belong to. And once we identify that, there can be specific planning. Again, looking forward to future episodes, how is it that we can plan things prior to that that will either cause it to be avoided or to be lessened in intensity. There may be engagement and outreach that needs to be done with the patient to have them participate, and it may be some administrative steps that are involved, enrolling them in programs and the like. And then ultimately, care plans can be produced, and episodes, interventions, or pre-episode interventions can happen, with the idea that if we have some additional involvement from the care team in these proactive steps before the next episode, then we can try to lessen the severity of that next episode or avoid it altogether. And so this idea of proactive outreach into the community in order to prevent things from happening starts to get at, I think, the promise of population health management. But there's one other step that we can think of in this vein to get to what I'll call full population health management. And of course, it starts with this idea of care teams who are already formed and ready to receive this population. But we start to characterize the patients before they show up. So it's not just looking at the patients that come across the threshold, but starting to look at all the possible patients that I can get my hands on and characterizing that population early, so that we can identify which are the best targets that we should spend our constrained resources reaching out to and doing some of these interventions. That may be creating a number of different panels of interest and assigning them to different care teams, et cetera. There's a planning that can go on to see what specific things are applied to a patient, understanding their history and the risk that we determined when we characterize them. And then we can, make sure that everyone, that the patients have some outreach that is performed to make sure that they are willing to be partners in their care. And I think that was a point that was brought up as a criterion for the pathway home. And once that outreach is done, the engagement of both the teams and the clients can be done. And of course, any interventions that are thought to be needed to prevent the episode or to lessen its severity can be done and planned for in a structured way. And so when the patient presents, all the normal things go on, all the episode encounter and the proactive management, but it's with this idea that we're trying to be proactive and capture all the patients that we can that are going to present or that are likely to present. And we try to do that for the idea of making sure that the episodes are lessened. So you saw the different criteria and the processes that were discussed in the Pathway Home. And I think that while it has a more narrow focus than what I'm talking about, more generically, the principles that were espoused fit very nicely into the idea of what I'll call mature population health management. Certainly there's a population characterization that was thought out in advance and could be applied to not just patients who have been seen, but also patients that could have been attributed in some other way. There's an intensive activity that leads into proactive management that is done even when they're in the hospital setting and preparing to move forward. There's a continual reassessment of their needs so that the planning and the outreach activities can be accounted for. And then, of course, as the intensity that's required for any given patient lessens, those patients can transition into other phases of care. And the services that can be enacted and deactivated and resurrected as needed really speak to this idea of proactive management. And so through that, we're able to really try to get our arms around as much of the patient population in a proactive way as possible. And through that addressing of the entire population deliberately, can start to do things that we hope will make that presentation of a patient in a care setting something that is easier to deal with and has better likelihood of outcomes for the patients. And so the summary of that is to say how one approaches population health matters. Being proactive and continually engage with patients at an appropriate level of intensity, that characterizes this idea of mature population health management. I think we saw that in the presentation for Pathway Home from CDC, but it's not just the care outcomes and quality outcomes, but there is a financial aspect that sometimes is made to be the villain, that people talk about it as it's almost crass to discuss the money. But as we see, if the money is and the reduction of cost is not taken into account, then the result may be the care providers who are doing all of this yeoman's work may not be able to sustain their models. And so I wanted to end with that because our goal in providing these webinars is to really advance this cause of population health management and to find real-world examples where there's success being had, and we heard one of those today. So we have just a few minutes left, and we'll move into a period of Q&A, and maybe I'll start by just seeing Danica and Mark if there's any particular reaction or thoughts that you have having based on the talk that I just gave.
We both agreed that your presentation is particularly around mature population health management fit with where we would also like to go. And I think that it flowed quite nicely, and we're appreciative and also would probably want to look more deeply into how we as an organization could be more proactive. Our questions too are around access to data to be more proactive in the absence of consent. So looking at information on a broader scale to identify individuals, but you could also look for particularly in New York City, I imagine that you would apply this on a geographic basis. So if you're seeing condition-specific issues around neighborhoods or communities, that may also drive where you'd want to place the staff of doing proactive care management.
Indeed, I think that I think that we're all sort of going through the growing pains of learning how those things can be done, and it sounds like, you know, those are some of the emerging blueprints and challenges that are there. So there are a few questions that I wanted to ask you. One that's come from the audience, and it was related to one I was going to ask myself, is for the Pathway program, how do you continue to run the program after the 1 year of funding ends?
That's a good question, and we were fortunate that because of the outcomes that we had, particularly amongst state patients coming from state psychiatric facilities, our State Office of Mental Health moved forward to fund the program after our grant ended. And so there were slight changes in that it wasn't just Medicaid recipients anymore. We were able to expand that to undocumented, but it was a focus more on individuals coming from state psychiatric centers or who were in our regular hospital system and at risk of going to a state facility. But beyond just the existing programs, they actually added additional funding so we could serve individuals in a different borough. So we now serve 4 boroughs in New York City out of the 5 and work with another state hospital. So that is how we've been able to continue with that program. But we've also received funding to start a small program just to focus working on homeless individuals in the Bronx in northern New York City, which is kind of exciting. It's just actually started operating last week.
Fantastic. Is there any sense of the amount of time or other measure you might have of the level of effort that's spent with clients in these more intensive transition periods that, you know, through this Pathway Home versus what they would have normally received? Like, how much more intense is a typical case?
So I can answer that with regard to our care management intervention. As we mentioned, I think many states are doing the health home care management approach, which arguably manages the network of services. It isn't a direct intervention as Pathway Home is. So typically, even for an individual with a designation of a high acuity, which would ideally be that they would be in need for more intensive services, because the caseloads are higher, an individual could get one face-to-face, which could be an hour or 2 a month. And a Pathway Home recipient, especially within the first 2 weeks of discharge from the inpatient facility, can get up to 7-8 hours in a day if the person is in need of those services. It can be flexible. So if we were to break down the differences, I would say that it's a drastic difference in not only face-to-face time, but access the time via phone, text messaging, and so forth.
And in terms of thinking of the long-term sustainability of that level of intensity, are you seeing, I don't know what interaction the program has with various payers other than the programs that you talked about with the government, but are you seeing in the future programs and contracts that payers would support that you think would enable this level of intervention into a more routine thing?
We are. So along with payers, we're seeing in New York the Delivery System Reform Incentive Payment Program, otherwise known as DSRIP, the state's goal to decrease hospitalization by 25% over the next 5 years. The participating provider systems, or these larger networks, are also aligned to want to invest in programs like this that will help them achieve an overall reduction of costs. So we think it's important to meet with both, but frankly, successful outcomes create that interest. And because we've been able to demonstrate the success of this program as evidenced by these outcomes, we're at a place that would advance the goals and the process of these PPSs who, frankly, are seeking solutions that can contain costs over time. I also want to highlight that part of New York State's goal is to ensure that community providers are working together, and participating provider systems are wanting to create these networks. And our program, just to be clear, CBC is the administrative technology and quality service arm, but the direct service is provided by our subcontracted agencies who have that expertise in the community. So we have been able to use those supports to stitch together the network successfully.
Great. And then the last question I'll ask, being sensitive to the time, you talked about ways that you're measuring, and you shared some of your success metrics with us, and you talked a little about being able to include process metrics as well. Are you also seeing that as you go through and measure that there are best practices or new protocols that can be sort of memorialized as a template for care? Are those kinds of things emerging as well?
The two that come to mind right off the top of our heads are ensuring that we track and close referral loops in a timely manner. And also, Mark talked about that we've created this culture of rapid response, and we're finding the need to define that rapid response to ensure that we uphold standards for ensuring that we respond timely and then that we close referral loops. The other process metric that makes, we had talked about is timely documentation. Anything that?
No, I think they're the main areas. And I think as we have learned over the course, this program's been operating 2.5 years now, we've made adjustments. And so with that timely responsiveness and the importance of that, we've been able to hire an intake manager who works with connecting with all the hospitals so that we can respond, see the patient in a timely, before they're discharged, so we can really do what we say we do, because we see the success of the outcomes when we have that early intervention.
Great. Well, I want to thank you again, Danica and Mark, for participating today and sharing your exciting results and a description of the good work that's going on in New York. To all of you who've tuned in, we appreciate your participation and your thoughtful questions. We will, as stated, send out a link to you so that you can have access to the recording of this session as well as the presentation materials. And please be on the lookout for future webinars. We think that all of us learning together is really what's going to move the needle in the delivery of care. So thank you very much for your participation today, and have a wonderful afternoon.
You too.
Thank you.